All right, so I'm going to talk about back pain. Anybody in the room never had back pain in their life? Raise their hand. No? Okay, so you're humans then. Good. So there's no alien in this room. So these are my disclosures. I'm an advisor and speaker and investigator for many companies. We're going to first talk about the problem of back pain, and then we'll try to go in a very easy way to know how to conclude that, because it's very common in everybody's practice. Back pain, the most common musculoskeletal complaint, most common work-related injury. 80% of us will experience low back pain. I think 100%, not 80. And more than 50 billion spent annually only in the United States on back pain. So let's look at the numbers, and let's look at the musculoskeletal problems that we're facing. All right. Let's look at the numbers and look at the musculoskeletal problems that we're facing and how many patients we have and how many rheumatologists we have. So this is not from Kuwait, this is from the US, but the United States is a country that kind of representative of the world because of the multi-ethnicity that they have. So around 15 to 20% of the population have musculoskeletal disorders generally. Most of them are osteoarthritis and back pain. Rheumatoid arthritis constitute only 1% or 2% in some population. Crystal arthropathy, as Tosin was talking about, is 1%. But you know, if we translate these small numbers, the 1% and 2% in Kuwait, it's going to be these numbers on the right. So if we're looking at rheumatoid arthritis, 1% equals 35,000 patients. Do you know how many rheumatologists are in Kuwait? I'm talking about certified rheumatologists who have a degree in rheumatology, around 35. So each rheumatologist has 1,000 patients of rheumatoid arthritis only, and maybe 1,000 patients of gout. But gout, because it's treated by other specialties. Now let's go look at back pain, which we're talking about. We're talking about 15%. So more than 500,000 people will have back pain in this country. And what is the economic burden on that? It's a huge. So back pain is one of the main reasons for work loss and major cost to the Western society. Recurrent and chronic pain account for 75 to 55% of total workers. And this is the most common cause why people don't go to work. And of course, it's cost because of the consultation, imaging, physiotherapy, medications, all these are counted. That's as cost of back pain. So what's the impact of back pain on patients' life? Over half of the chronic back pain patients may suffer from insomnia. Back pain may also have psychological effect, emotional stress, relationship breakdowns, severe emotional distress to the partners, and limitations to fulfilling their family role. So it is a problem, need to be addressed very early and referred to the right person. And it is very important to differentiate between mechanical and inflammatory back pain, because those patients who have inflammatory back pain who don't get to the right place may end up in a lot of problem. So it is important to distinguish inflammatory from mechanical as early as possible, as management and treatment of those two conditions is very different. So patients may have symptoms of inflammatory back pain. You know that ankylosing spondylitis is the one that we are addressing here, or what we call the spondyloarthropathy, and this is a new terminology. So patients may have symptoms of back pain for a very long time before they go and consult doctors, because this pain improves with activity, and it's in young people who are very active. And if you can see from this figure, that's 50% of the patients actually seek medical attention after 1 year. So they have back pain for a year before they go and see a doctor. Because they take non-steroidal, they improve, they exercise, they improve, they walk, they improve. And why is that not moving? All right. I don't know why this is happening. So we're here, and then we're going to come here. All right. So causes of low back pain. We can go anatomical, so structural, mechanical, which is the most common. Then we have the inflammatory that we deal with. We have metabolic and neoplastic, which are also rare. And then we have abdominal and visceral. As you know, pancreatitis, cholecystitis, abdominal aorta, all these organs can give back pain as well and should be also kept in mind. Now, this will summarize to you the causes of back pain. 97% is mechanical. But we really also care about this 1%, which is coming to more than 30,000 patients. Okay? So this is the reason. This is also to tell you that don't consider that every patient you see with a back pain that have ankylosing spondylitis, most of the time it's mechanical, but it is important to know which one is inflammatory. So let's come now a little bit to this structural and mechanical causes, because you're going to see a lot of patients who come to your clinic with imaging, and you just want to see, is this imaging relative to their symptoms? So we'll come to this classification, looking on the structural classification. So we have prolapsed vertebral disc, lumbar spondylosis, spondylolisthesis, spinal stenosis, fractures, diffuse idiopathic skeletal hyperosteosis, and non-specific. And the non-specific one is the one that you are actually experiencing the most, and it is more than 80% of the time. So let's come to these terminologies. So when we see the imaging, we understand what people are talking about very easily. Spondylosis, and I'm going to show you pictures of each of them. Spondylosis is degenerative changes both in the intervertebral disc and the facet joints. And this is the most common, and it happens with aging. Okay? Spondylitis is the one that we see, which have inflammation, and this is ankylosing spondylitis. Spondylolisthesis, spondylolysis, a defect in the pars interarticularis of the vertebra. I was going to show you a picture of that. And spondylolisthesis is forward displacement of one vertebra over the other. It is important to understand that and to see if what they have is related to their pain or not when they show you the image. So let's start with that, spondylosis. And this is what we can see, that osteophytes and is the major finding in those patients. And this is not really difficult for the radiologist to diagnose. And then we have very advanced spondylitis, as you can see, the bamboo spine, and the bridging between the vertebra. And we're going to go into more of details of that at the end. Then we have the spondylitis, which we have a defect in the vertebra itself, and this is congenital. And you know what? It looks bad on the imaging, but most of the time it's not that painful. Patients are living with that. And we cannot always blame this defect for the pain that they have. But it's important to know what it is. And this shows it better here. And then we have the spondylolisthesis, where as you can see, that the spine is not aligned all the way down. There's some displacement between the vertebra, and this is also congenital. This can cause chronic nagging pain if we excluded all the other causes. But it's not uncommon. You can see that a lot. And this one looks really bad, but it's not. This is what we call DISH, diffuse idiopathic skeletal hyperosteosis. You can see that the X-ray shows a lot of bony changes and calcifications and stuff. Those patients usually, they don't have too much pain, they have more of stiffness. And it's common actually in diabetes. So if you do an X-ray of patients who have diabetes, you might see something like that. All right. Now, the first classification was anatomical, structural. Let's come now to the syndromes, how to classify the syndrome. We have the acute low back pain, which we probably all had. We have the chronic low back pain, which hopefully nobody has. And then we have the nerve root compression syndromes, which are acute, but we put them separately, and hopefully nobody has. And of course, we have the spinal stenosis there as well. So let's come to the acute low back pain. I had one just in Ramadan. For the first 2 weeks, it was very embarrassing for me to have back pain when my patients see me and tell me, listen, how come you have back pain and you're our doctor? You should not suffer like that. But it happens and takes time to go. So it may follow an injury of a trivial strain. You really don't have to do a lot of work to get that. One time I was trying to put on my pant and suddenly my back hurts, and that's lasted for a few days. It happens like that. Generally, it's of short duration. Recurrence common. Patient present with severe back pain. Decreased range of movement, they're usually stooping, they cannot stand up straight. And when you examine them, their paravertebral muscles are very tight. And it's okay to defer full examination and X-ray if the patients have it very acutely, and there's no significant neurological symptoms. Because a lot of those patients come on a wheelchair, they can't stand up, you want to put them on the bed and put them on that, and they really don't want to move. So if they don't have a lot, or not a lot, if they don't have significant neurological symptoms, you just can, defer the physical exam. And you know what? All treatment work. Sometimes somebody will tell you, somebody gave me this, another will tell you, somebody gave me that, and somebody said, my mother said me, everything works. Everybody can be doctor for acute low back pain. How about chronic low back pain? This is usually the difficult one. Most of the time, the cause is difficult to know why. Variable clinical spectrum, nagging mechanical low back pain, periods of acute exacerbation, variable muscle spasm, and decreased range of movement. And refractory to treatment, unfortunately. And those patients usually should not be treated in your clinic, nor in my clinic. Those patients should go to the rehabilitation medicine to have a structured program for their management. Let's come now to the nerve root compression syndrome. And this is disc herniation. 95% of the time it's L5-S1 or L4-L5. Large central herniation, which can cause Coda equina syndrome, is very serious. Those patients usually have numbness and loss of sensation around their perianal area. Those patients have to be rushed to the hospital, and they have to do an emergency MRI, and they have to have an emergency surgery. Maybe this is the only reason why you can bring a radiologist at 4 o'clock in the morning to do an MRI for you, if you tell him Coda equina syndrome, because if he doesn't come, he's going to get in trouble. And onset may follow back injury, usually trivial, carrying something, doing something wrong, and suddenly a really acute pain with neurological symptoms. All right, so paravertebral muscle will go into spasm to protect you from moving, loss of lumbar lordosis, limited spinal movement, a straight leg raise positive, which I'm going to show you in a second, and the presence of for flexed position, as you can see here. The patients will be stooping like that. Neurological signs are variable and depend on the route that it gets involved. So this is the straight leg raise. It's really a very easy test to do in the clinic. Ask the patient to lie down and raise his leg a little bit gradually, of course, until you reach 30 degrees and more. They'll start to have pain in their back. This is a positive sign. And if you raise the right leg and the pain is on the left side, this is even more positive. So this is a very easy way to do the test in the clinic. All right? Now, spinal stenosis. Spinal stenosis is very easily missed. It causes pseudoclaudication. The patients start to walk, and they have symptoms such as vascular claudication. They have unsteady gait, lumbar pain, usually mild, range of movement may be normal, and straight leg raise is negative. So their pain is mostly when they walk. And patients who have vascular claudication, when they sit down and rest, within a few minutes, the pain in their leg will improve. Like angina, right? They improve. With those, it doesn't improve very quickly. If they start to walk and they start to get back pain and they start to the pain gets to both lower limbs, usually in the thighs, and they sit down and rest, this is going to take a while for them to improve. And this is when I start to suspect that. So if you can see here in the picture, what spinal stenosis is basically the bone is growing inside the canal of the spinal cord, and it's causing compression, and with walking, this spinal cord will get suffocated. So let's come to that to summarize how can we differentiate between mechanical and inflammatory. Onset of mechanical at any age, inflammatory usually younger, less than 45. But it doesn't mean that they can't get it, but most of them usually, when you see them, even if they're in their 60s, they will tell you that the pain started 20 years ago. How about the duration? With the mechanical, it's usually less than 3 months. With the inflammatory, it's usually chronic, more than 3 months. The onset with the mechanical is acute or subacute, and the patient will remember exactly when it happened. If you come to the patient with ankylosing spondylitis, they usually can't tell you. They tell you maybe 2 years, or maybe 5 years, they wouldn't know. They can't really remember when it did start. Early morning stiffness is something that we look at. It's helpful in the diagnosis. Patients who have inflammatory arthritis, they have prolonged early morning stiffness. Most of the time, it's more than an hour, but more than 30 minutes, we find it significant. Response to non-steroidal is very important also. Patients who have mechanical, their response to non-steroidal is partial, but patients who have inflammatory, if we give them non-steroidal, it works very quickly and they improve a lot. How about other signs? Alternative buttock pain, worse at night. This happens with the inflammatory. Enthesitis, which is inflammation of the tendon or ligament, like plantar fasciitis, epicondylitis, whatever. It happens more with the inflammatory at the same time when they have back pain. And peripheral arthritis obviously happens with the spondyloarthropathy more than the mechanical. Now, spondyloarthropathy, what we usually call them SPA, there are too many diseases, but they're very linked because they overlap. We have the ankylosing spondylitis, psoriatic arthritis, we have the Crohn's or the IBD related, we have the reactive arthritis. Also, patients may have anterior uveitis with back pain. They're genetically linked very much, and a lot of patients have more than one at the same time, and most of them have relatives who have the same disease. So let's come to the spondyloarthritis. An alternative scheme classifies SPA according to whether the joint involvement is predominantly axial or peripheral. So some patients may have spondyloarthritis with mostly peripheral, some of them axial, some of them mixed. So the axial, with predominantly axial involvement, neck, mid, back, low back, is sacroiliac. Peripheral, obviously, the extremities. And these are the distinguishing features of patients who have spondyloarthritis. They have inflammatory arthritis, asymmetrical arthritis, dactylitis, enthesitis. They may have extra-articular manifestation like skin lesions, bowel inflammation. They also, a lot of them have the infection triggering it, family history, and elevated ACR. Obviously, you don't need to memorize all that, but this is just a hint when somebody comes with a back pain, it's very wise to ask about extra-articular manifestation and also do a CRP for them and ask about their family history. And this is the ESAS criteria, and I can tell you that none of the rheumatologists memorize these. These are most helpful for research purposes, but it also gives us a lot of information about what should we ask about and what's not. So, doing an MRI or imaging, helpful. Knowing HLA-B27 is helpful, in addition to taking full history and do full physical examination. And remembering, skin, gut, eye. Those are the three main organs that will be very helpful. Now let's come to the sacroiliac joint, which is the main site affected in patients with inflammatory arthritis. So as you can see, this is a normal X-ray. You can see that the sacroiliac joints are patent. Let me see if that's, oops, what did I just do? Okay, let me just go back. Which one is the pointer? Which one? This one? No, I need the pointer on the, if I can point there. I press here? Oh, really? Okay. Oh, nice. Thank you. All right. So, and is it? Oh, okay. So these are the sacroiliac joints, as you can see here. All right. And then let's go down and see, this is a sacroiliac joint, which is, here it's not normal. As you can see, there's bridging. And this is more advanced, as you can see, ulceration here and sclerosis. And this is almost ankylosed, fused. And this is here shows you the stages where patient start with reduced demarcation of the space, then they may get some erosions, then they get bridging, and then they may get complete ankylosis. Okay, so X-ray helps in the diagnosis. But luckily that we start to understand the disease more, and we start to use more technology to diagnose patients very early, even if they have normal X-ray. And as Dr. Heba mentioned earlier, the idea is not only to diagnose. The idea is to diagnose as early as possible to prevent damage and complication. If we want to rely on the X-rays to diagnose ankylosing spondylitis. That means we have to wait for 8 years, 7 years, 6 years to tell him your x-ray now shows changes. And he's been having this inflammation for a very, very long time without diagnosis. Now we understand, we are using now MRI to diagnose. Doing an MRI of the sacroiliac joint can show changes that do not show on x-ray, as you can see here. So what we can see here, this is called bone marrow edema. This white changes here, and this white changes here. This will never ever show on an x-ray. This is fluid around the joint, highly suggestive of inflammation of the sacroiliac joint. And we have diagnosed many, many, many patients who have completely normal x-ray, especially women, by doing an MRI, showing these changes, starting treatment, and changing their life. All right, so, and now let me try to move. So, what is ankylosing spondylitis? It's part of the spondyloarthropathy. But this disease is a chronic progressive inflammatory arthritis, predominantly affects the spine and the sacroiliac joints. It's characterized by sacroiliitis, enthesitis, and a marked propensity for the sacroiliac joint and the spinal fusion. All right? And usually the inflammation happens on the ligament level. All right? Diagnosis is by X-ray and MRI. And as you can see here from that, what happens, usually inflammation of the ligaments that combines the vertebral bodies, and then erosion will happen and ossification will happen. In our bodies, the calcium goes to any area of inflammation like a magnet. Any place in the body that has chronic inflammation, calcium will go there and stay, will attach to it. And that happens on the level of the coronary arteries, happens on the level of the internal organs like the pancreas, anywhere else, and also the joints and the ligaments. When you have chronic inflammation there, those calcium is going to go and attach itself. With time, they will build up and create like a bone. So we don't want that to happen. All right, and why it's not moving now? I don't know why it's not moving. It's almost done by my slides, by the way. No? Perfect. So what is the goal of treatment of patients who have inflammatory arthritis of the spine, ankylosing spondylitis? Achieve disease remission or minimal disease activity. If we cannot reach remission, provide symptom relief, maintain function and workability, prevent complications of the spinal disease, and maintain spine flexibility and normal posture, minimize comorbidities and complications, as Dr. Huda was explaining to us, and minimize extra spinal and extra articular manifestation. So how do we manage those patients? Non-pharmacological intervention, patient education, it's very, very important. The patient has to understand what they have. Otherwise, they're going to go, they're not going to comply to treatment, not going to adhere. They're going to start to go from one doctor to the other. But the doctor has to spend some time to explain to them what's the problem. Smoking cessation is also important because it's known to make arthritis worse and interfere with our treatment. And physical therapy is as important as pharmacological therapy. Patients have to understand that exercise, not because we want them to be healthy, but actually it slows down the progression of the disease as well. So we can use non-steroidal analgesia, we can give local injections if we have sometimes, and then sulfasalazine, which one of the treatment that works on the peripheral, doesn't work on the axial joint, like the sacroiliac joint. And luckily, we are rheumatologists in this time, where we can use biological therapy. We have anti-TNF therapy, we have 5 of them in Kuwait. We have 2 IL-17, and we also now, data shows that JAK inhibitors also works very well for patients with ankylosing spondylitis. So we have almost 10 biological therapy with smart therapy to treat those patients who have chronic disease and get them back to their normal life. We rarely reach out to the surgeons to do surgery for us. And once we do that, we knew that we failed. So we always try to keep our patients as healthy as possible without doing any surgical intervention as much as we can. But non-steroidal, as effective as it is to the patients to improving their symptoms and making them better and slow their progression, there's a lot of limitation to that. Because those patients have chronic disease at a young age, we cannot give them non-steroidal forever. Non-steroidal may harm their gastric mucosa and also can cause renal impairment. And we don't want that. So we can use it for a short period of time, intermittently sometimes, but once the patient's demand for non-steroidal become unacceptable for us, we proceed to go to the biological therapy. So, we came to the end. Take-home messages: inflammatory back pain starts before the age of 40, wakes you up in the middle of night, feels better with movement and exercise. Taking non-steroidal helps a lot, and feels stiff first thing in the morning for 30 minutes. Those questions that probably need to ask the patients who come to your clinic, especially if they're young and they have it for a while. All right, now, last take-home message, and if you want to remember something from my presentation, this is one of the things that you probably need to remember. I see a lot of patients with MRI, a lot of patients who tells me, I have a disc problem. I'm diagnosed to have a disc problem, and they're in their 30s, and they're diagnosed with a disc problem in their 20s, and no trauma, nothing. Why? Because somebody said that you have to do an MRI, and they did the MRI for them. And you know what? MRI testing is misleading in a lot of occasions. MRI testing of asymptomatic population, asymptomatic, no back pain, okay, reveals 50% have disc bulge, 25% have disc protrusion. Imagine that. So if I take all of you now, there's around 100 people in this room, and I tell you, if you don't have anybody who I'm going to do an MRI should have no back pain, and enter that, 50% of you will have something abnormal. And maybe you have back pain, but whatever you see in the MRI is not related to it at all. And those patients, unfortunately, do have ankylosing spondylitis. And nobody imaged the sacroiliac joint, and they imaged above the sacroiliac joint to see the spine. And they find these things, and they tell him, you have a disc. And the patient lives with that and mislead the next doctor when they see him for their back pain. So be careful when you see an MRI. Having an abnormal MRI is not always abnormal. And sometimes having an abnormal MRI does not have to do anything with the patient's symptom. Okay? And with that, I come to the end of my presentation, and let me know if you have any questions.
Continue his life, or no, totally rest at home, or refer to do X-ray?
Duration is important. How long?
Just for 1 day after moving a heavy box.
Okay. As we said, if the patient does not have significant neurological symptoms, numbness or weakness,
Yeah.
if you're going to send this patient for imaging, you're going to get into a lot of trouble with that. I would advise you treat the patient with non-steroidal analgesia, depending on his condition, and let him rest for a few days. I start to get alarmed if the pain lasted more than a month. Before that, it will improve. Most of the time, it will go away even without your intervention. The body has the way to fix itself, by the way. What we do is to help and make it more pleasant. All right?
Okay, thank you, doctor.
Any other question? No questions? Okay. Anyways, we're going to be around for any questions. Now, we do have a break. We have 2 workshops that are going to happen in this room. This room is going to be divided in 2. There's another room outside here, and there's another room there. You're going to see our names on that after the break. I would really like to thank you for being here, and I hopefully that we have able to deliver some messages to us. Before we go to the break, we would like to appreciate our sponsors, our speakers, to give them their trophy. You're welcome to stay here for that. Lunch will be provided. Prayer time, place to pray is also there during this break. It's going to be around an hour. And don't forget to scan your, ID. All right, so I think the first, can I have a Yes, please. So we always have to thank the pharmacological companies for their continuous support. For us as rheumatologists, we're very lucky to have very supportive companies to help us to always get engaged in scientific activities with our colleagues. So we have our first, okay. So I think we're going to first thank them all,